Hey guys, welcome to 5 Questions with Conan. I thought this would be a fun little video series to start. I thought it'd be a cool thing to go over some questions with you guys, show you my thought process, and also make mistakes together, let you know how my thought process is for making a study card or a flashcard on that material and making sure I really retain it in the future. And doing questions together, I've always found to be a fun and engaging exercise. And so I hope you guys actually enjoy doing this little journey with me as well. We'll see how it does. And yeah, I'm excited to try it out. So let's see. Let's just start our first practice exam here. So we're on MKSAP 18, and we're going to create a practice exam, or a custom quiz, rather. We'll do the study mode. And I'm actually going to select all of the different subspecialties, so that way it's not just giving me a bias of one particular specialty. I'm not sure what the virtual diagnostic questions are, but yeah, we'll just do these MKSAP 18 and extension questions. And let's just do 5 questions and let's see how it goes. So let's quiz number 1 is going to be October 12th, 2022, and let's get started. So our first question, the way I typically like to approach these questions is I usually like to start reading with the first sentence. So a 56-year-old man is evaluated in the emergency department for progressive chest pain and dyspnea that began 3 hours ago. And right now I'm starting to realize that reading this to you guys while I'm doing the test question is definitely going to make it a little bit harder and definitely going to be a little bit more pressure. So, I mean, I'm definitely going to get some more questions wrong. And so then I just go straight to kind of the last couple of sentences. So aspirin is initiated, and which of the following is the most appropriate immediate management? And then I first kind of just like to look at the answers first, because that gives me a sense of what the question is really going to be like looking for, and what things I need to look for in the question stem in order to rule out certain answers. And then I'll go back and kind of read the rest of it. And that's basically my preferred way to approach questions. So one answer is admission to the ICU for medical stabilization, IV metoprolol, PCI, sublingual nitroglycerin, or thrombolytic therapy. And so these are definitely things I'm going to be keeping in mind. Sounds like this is going to be some kind of ACS question. And so if they need ICU medical stabilization, usually you would do some kind of procedure beforehand. IV metoprolol is going to be if they're in like AFib with RVR. PCI is going to be if they're at a PCI capable facility and they're having like an MI, a STEMI, then we should do that. Sublingual nitroglycerin is just going to be like for pain, and thrombolytic is going to be if they're not at a PCI capable facility. Because I'm already starting to notice some ST elevations on this EKG here. So anyways, medical history is significant for hypertension treated with lisinopril. On physical exam, he is confused. Blood pressure is 86/50, pulse 118, respiratory rate 24, O2 sat is 90%, S3 gallop, suggesting some volume overload, and crackles noted on pulmonary exam. Extremities are cool to the touch. So they're kind of giving some kind of signs of like cardiogenic shock, to be honest, with this pulmonary edema and just these signs of volume overload in general. And then, right, so, we're seeing multiple ST elevations here, V2, V3, V4, V5, V6. So this is like a massive MI. Lead 1 also has an ST elevation. And then we've got some reciprocal ST depressions over here in the inferior leads. And so this is clearly going to be a STEMI. And one thing to note, one teaching point I want to go over with you guys is that an ST elevation is considered a 1 millimeter ST segment elevation compared to the TP segment, which is from the T wave to the P wave. And that holds true for every lead except for V2 and V3. So in lead V2 and V3, there are actually slightly more lenient criteria for STEMI in lead V2 and V3. So in men less than age 40, let's just pull this up for you guys. So in lead V2 and V3 for men less than age 40, you need a 2.5 millimeter ST elevation in order to consider it ST elevation. If they're greater than age 40, then it's 2 millimeters. And then women or females of all ages need to have a threshold of 1.5 millimeters in order to consider an ST elevation. So that's one important thing to know. Clearly, in this case, this person has multiple ST elevations and multiple other leads, and they probably have let's see, he's 56 years old, so he needs a 2 millimeter elevation, and he's basically, he's got a 2 millimeter elevation. There's 2 boxes in between here. So yeah, this is definitely a pretty easy one. It's going to be a PCI. If they said that they weren't in a PCI capable facility, then we would do thrombolytic therapy. But this is like a door to balloon time, less than 90 minutes or whatever. So we just need to do PCI, and that is the correct answer. So educational objective: treat ST elevation MI complicated by cardiogenic shock. Yep, and then thrombolytic therapy would be indicated if transfer to PCI capable center would result in first medical contact to device time of more than 120 minutes. And I'd actually have to go back to my previous video, Resident's Guide to Acute Coronary Syndrome, because I kind of forgot some of the exact criteria. And, this is why medicine is like a, ongoing thing where you have to go back and like review things all the time. So if a PCI capable facility, you're looking for a door to balloon time of less than 90 minutes. And then a non-PCI capable facility, you give thrombolytics if you can't get them to a facility within 120 minutes, and you should get them those thrombolytics within 30 minutes. Anyways, that's question number 1. So let's move on to question number 2. So a 44-year-old man is evaluated for a 6-year history of constant low-grade perineal pain with intermittent exacerbations and intermittent urinary symptoms of dysuria, frequency, and urgency. So right now I'm already thinking of like some chronic like bacterial prostatitis kind of things based on this kind of history. It's already like a kind of middle-aged man with these chronic urinary symptoms. And so which of the following is the most appropriate pharmacologic treatment? Lidocaine, hydrocortisone, pregabalin, tamsulosin, and trimethoprim, sulfamethoxazole. This is difficult. So I really don't know what this suppository is going to be talking about. And pregabalin, I don't really know of anything this would be treating, unless this is some kind of nerve thing. I really don't think so. So really what this is coming down to is, do we think this is just BPH, and we'll treat it with some tamsulosin, or do we think this is some kind of prostatitis that needs to be treated with an antibiotic? The problem is I don't think Bactrim is really an appropriate antibiotic for treating chronic bacterial prostatitis. And this is, again, something that I would have to review a little bit more frequently. But let's see. Here's a documented case of acute bacterial prostatitis 6 years ago. So what I was kind of thinking. Since then, he has undergone extensive urologic evaluation during many of his exacerbations, all with negative findings. He has been treated numerous times with antibiotics, anti-inflammatory agents, and alpha blockers without symptomatic benefit. He has no other medical problems and currently takes no medications. On physical exam, vitals are normal. Prostate yields mild and poorly localized tenderness without masses or nodules. There is no penile discharge or scrotal pain on palpation. Results of labs reveal normal ESR, CRP, leukocyte, creatinine, electrolyte, and serum PSA level. Post-void residual ultrasound was normal. Oh, this is a really, really difficult one for me, because this person obviously has a very complicated urologic history, at least for an internist perspective. And I would have assumed that if he's already gotten treated this many times with antibiotics, then Bactrim is not really going to help that much. BPH really shouldn't be causing this many symptoms and shouldn't be causing tenderness on the prostate. The fact that he's received so many antibiotics already without benefit. Oh, this is a really hard one, actually. I think I'm going to get my first one wrong already. I don't know this one. I really don't think it's a suppository and pregabalin, because I honestly have never heard of those treatments for like prostatitis or chronic prostatitis, but maybe there is some utility to like pregabalin in this situation, because I know in females, you do tend to get this like interstitial cystitis thing when people have like these recurrent symptoms, and it's really just like this kind of functional pain. The fact that he hasn't improved with multiple antibiotics, I'm sure they've used fluoroquinolones and like haven't, man, I honestly just don't know. I don't want to get this question wrong. I feel like I'm just gonna guess something random though. Like right now, I'm really actually starting to lean towards this pregabalin, because I don't feel like it's BPH. I don't feel like it's tamsulosin, and I don't feel like it's Bactrim when he's already completed multiple antibiotics. And the suppository just doesn't make any sense to me. It just feels so wrong to pick pregabalin. I don't know. I think I'm gonna be a big idiot here. Kind of embarrassed. Shoot. Okay, yeah, I don't think this is BPH. And I don't know the utility of treating somebody with Flomax for these chronic prostatitis symptoms, but maybe there's some neurogenic kind of component to it. So I'm just going to go really YOLO and just pick pregabalin and see what happens. Oh, let's go, baby. Oh my God, that was a freaking hard one. I did not know this one. Chronic pelvic pain syndrome. I have maybe vaguely heard about that, but honestly, that was a really hard one for me. Wow, I'm actually really I'm really happy that I actually ended up getting it, because that was a really hard one. So a trial of pregabalin is the most appropriate treatment for this patient with chronic pelvic pain syndrome. CPPS is characterized by chronic pelvic pain and intermittent voiding symptoms without evidence of infection. This basically feels like interstitial cystitis, but for men, at least from what I'm hearing here. And this patient has already tried numerous medication regimens without symptomatic improvement. So it would be most prudent to proceed with a neuromodulatory approach. Interesting. So this is one that I would potentially make a flashcard on. And, I don't really know how high yield this is for me. But I just did want to kind of show you my process for making a flashcard really quick. And usually I make flashcards for questions that I get wrong. So first of all, let me just check if I have anything on chronic pelvic pain syndrome. I bet I probably do. Let's see. Here we go. Young male patient with sterile urine but irritative voiding symptoms, perineal pain, and pain on ejaculation for several months. Chronic prostatitis / chronic pelvic pain syndrome. Must be greater than 3 months without an identifiable cause. Treatment includes antibiotics, alpha blockers, and 5-alpha reductase inhibitors. Chronic bacterial prostatitis would present with a history of UTI and have a tender prostate. BPH does not typically cause pain. And you can see here that my interstitial cystitis kind of shows up here as well. So in this case, interesting that I actually did not have anything that talked about modulatory blockade here. So what I could do here is just add neuromodulatory agents. I could add there. And really, when I'm making a card, it just has to go down to the key one piece of information that I needed to know. And the one piece, you don't want to overburden yourself by making too many cards on a question. You really want to focus on one or two high yield things that you didn't know and that caused you to get the question wrong. And so in this case, there's multiple cards I could make on this. I could make more cards on this chronic pelvic pain syndrome because I didn't really get that. Although I kind of vaguely had gotten to that point by myself. But in this case, the main question that I didn't know was, can pregabalin or neuromodulatory agents be used for chronic pelvic pain syndrome? And so in order to make that question, every time you make a card, you want to make it, as discrete as possible. So there's only one possible answer, and it's a very clear answer, and it's not this long-winded paragraph or anything. So it's really just as simple as, is pregabalin indicated for the treatment of chronic pelvic pain syndrome? And the answer would just be yes. And this would just remind me about this card that I got, basically almost got wrong, but I ended up, doing process of elimination to get it right. And then I can add some information here. So I could write neuromodulatory agents such as pregabalin, gabapentin, and nortriptyline, I believe. Triptyline can be indicated. Question stem may show young patient with chronic prostate symptoms, dysuria with no evidence of infection or improvement with antibiotics. Okay, and then, I just, put some information here, but yeah, this is pretty much it. I just add a card like that. So let's just move quickly on to question number 3. I said 5 questions at first, but I'm realizing this is taking a little bit longer than I anticipated, just because there's a lot to go through with each question, especially when I'm recording it like this. But this is pretty fun. I'm hoping you're having fun going through these questions with me as well. So let's just do our third and last question now. So question number 3. This question has been invalidated as a result of post-publication analysis and or new data that are relevant to the question. Please select answer C to earn a point for this item. Interesting. A 31-year-old woman undergoes consultation for preventing traveler's diarrhea. She's going to Mexico. She has Crohn's colitis, adalimumab, allergic. What is the most appropriate post? So in this case, I'm just going to do this question anyways, but either a fluoroquinolone or azithromycin are appropriate treatments for traveler's diarrhea. But I wonder what they are saying is invalidated here. I have a card on this as well. So you can see what antibiotics are used to treat traveler's diarrhea, azithromycin in Asia due to fluoroquinolone resistance. However, treatment of diarrhea in general is not really recommended. Prophylaxis with bismuth-containing products and loperamide is recommended. So that may be what they are referring to in terms of this question being out of date. So now I'm looking at why they changed this question, and it says guidelines were updated. Ciprofloxacin is no longer recommended for prophylaxis. So there we go. Now we learned something new. So let's just do one more question because we kind of had a freebie on that one. So a 77-year-old man is evaluated for a 2-month history of worsening fatigue, increasing urination, nocturia, and anorexia. Like all these old guys with these like bladder problems, prostate problems. 9 centimeters kidneys without hydronephrosis or calculi bilaterally. Which of the following is the most likely cause of the patient's kidney findings? And just looking up here, I see the creatinine is 2.8, but it's up from 1.2. Aspirin, fenofibrate, omeprazole, and St. John's wort. Already, I'm kind of looking at omeprazole because PPIs are a very common cause of acute interstitial nephritis. Aspirin could cause toxicity. Fenofibrate and St. John's worts, I'm not totally sure of any clear association or that I know of for inducing an AKI. But anyways, 2 months of these symptoms. History significant for hypertension, hypertriglyceride, hypertriglyceridemia, GERD, and depression. He's been taking low-dose aspirin and valsartan for 10 years, omeprazole and St. John's worts for 8 months, so that definitely fits the timing, and fenofibrate for 2 months. On physical exam, blood pressure 150/79, pulse 82. Remainder of the exam is unremarkable. And basically, what I'm expecting to see if it's acute interstitial nephritis is that you're going to see white blood cells, but you're really not going to see that. You could see white blood cell casts on urine microscopy. Unfortunately, they don't give us that here. But the urine specific gravity here is telling this is definitely kind of a chronic process that's been going on. Trace blood. You can think about, some glomerular processes at that point, but I think it's probably just, a trace a little bit about blood. I wouldn't be too worried about it. And 2+ proteins, he's definitely spilling some protein. Again, potentially causing a glomerular process. But overall, I think the timing of the omeprazole being started 8 months ago, and then the fact that it's a very well-known cause of interstitial nephritis, and we're seeing some white blood cells here in the UA. I think this is pretty confidently omeprazole, unless there's some kind of association with fenofibrate that I'm not aware of, which it could be. The fenofibrate started once his 2-month history started, but I don't really know of an association. Oh, actually, I think there is an association. I think I did have a patient who had fenofibrate toxicity leading to an AKI. Oh, shoot. I'm actually pretty sure I had a patient who had fenofibrate toxicity leading to an AKI. Oh, I was so confident I was going to choose omeprazole, but actually, I'm pretty sure I'm going to choose fenofibrate now. The 2 months is like exactly when he started it. Was my patient on fenofibrate? They were on some kind of triglyceride lowering medication, and I think it was a fenofibrate. And I think it's associated with AKI. So, yeah, maybe let's go with fenofibrate. Oh, I thought it was omeprazole, but yeah, now I remember that patient that I saw. Ah, shoot, it was omeprazole. No, I got my first question wrong. PPI-induced tubulointerstitial nephritis. That's literally what I said. I'm pretty sure I saw a patient with fenofibrate-induced AKI. I literally saw no, maybe it was another lipid-lowering medication. Lipid-lowering drugs. Shoot. What? No, I'm pretty sure it's fenofibrate. Adverse reactions. AKI? Renal, acute kidney injury. Oh my God, I literally talked myself out of that because of a patient experience I had. Oh my God, it was so obvious. It was so obviously PPI. Oh my God. I talked myself. I feel so bad. I was going to try and keep it a 100% streak as much as possible. Oh man. But yeah, I mean, there's not much more to say. I think I knew the answer, but I ended up having a, personal patient experience actually lead me astray from the correct answer. So obviously, if you see PPI and you see white blood cells and AKI, you really, really should think about acute interstitial nephritis. The median time from drug initiation to interstitial nephritis is variable, but can exceed 6 to 9 months, with 10 to 11 weeks being the most common interval. Let's see. Phenofibrate nephrotoxicity is characterized by a rise in creatinine, typically 6 months after initiation of therapy. The sediment is bland and there is usually no significant proteinuria. Mechanism of increase of creatinine is unknown. So I was right. Okay, it does cause an AKI. And yeah, we definitely had a patient who started phenofibrate and started having an AKI. But I think basically based on the sediment being a little bit more active with the white blood cells and protein, it's supposed to make you think more of a tubulointerstitial nephritis. And yeah, St. John's wort does not seem to have any association with like an AKI or nephritis. So yeah, interesting question to finish on. I feel a little disappointed because I think I knew the answer, but talked myself out of it. But yeah, that's part of, going through these tests like this. Things like that do happen. I got kind of lucky on question number 2. So yeah, you win some and you lose some. So anyways, I hope this was like a fun experience for you guys. I'm definitely looking forward to doing some more questions. I think it's kind of fun to make it a little bit more of an interactive session, and it kind of motivates me to do more questions more frequently too. But I hope you enjoyed this video. Please let me know in the comments down below if you have any suggestions or what you thought of this video, or if you'd like to see the format changed or anything. And yeah, I'll see you in the next video. Thanks again for watching, and peace.